So in terms of disclosures, I don't have any financial arrangements related to the content of this activity, nor do the other presenters. The topic today is stages of change in the spirit of MI. I'm presenting today from slides that are adapted from those created by Dr. Fernandez, Dr. Lindsay, and our own Dr. Bott. Our objectives today are to identify the core concept of the trans-theoretical model of change so that you'll be able to apply these concepts to assessment and treatment, to review the foundational principles of motivational interviewing and its basic components as they apply across clinical settings, and then to develop an understanding of the philosophy and application of motivational interviewing in the context of case conceptualization and treatment planning. This is a pretty ambitious presentation in terms of how much information we pack in, so I'm going to move through it pretty quickly. Please make sure to note any questions or any points where you'd like more explanation in the chat so that we can return to it afterwards. So in terms of the trans-theoretical stages of change model, what this is an evidence-based model that matches where a patient is at with where they need to be in order to benefit from treatment. And that sounds really simple, but the reality is that when we miss that, when we undermatch or overmatch patients with treatment, we can very easily scare them off or even be counterproductive in their treatment. An important clarification, because stages of change model comes up so often alongside motivational interviewing. They are not the same thing. They're beautifully complementary. They can be utilized together, and we'll talk about that more, but important to remember they actually are two totally distinct models. So we'll start with the identifying characteristics of the stages of change model, and then we'll go to how they all fit together. In pre-contemplation, the person is simply not considering change at that time or considering it at such a subtle level that it's not really detectable. In the contemplation stage, they are considering change in the foreseeable future, but there's quite a lot of ambivalence. In preparation, they're planning on change in the immediate future, but they're still sort of marshaling their resources and thinking it over. In action, they are actually taking those steps. They're making changes, and those are meaningful changes, and it's in the recent past. And then in maintenance, that's when those action steps are becoming sustained and really integrated into their life. They've been able to keep them up for a significant period of time. And then very importantly, relapse is a step that is part of the stages of change model because it is so normal. And that's a return to the prior targeted behavior, or as we frame it within this model, a learning experience. So let's look at how these all fit together. One thing to note about the way the stage of change model is represented here, and this is the most common representation, is that even though it looks like a circle that goes in one direction, this is actually not a linear model. It's possible for patients to enter, to drop out, and to re-enter at any point in this model. This is just the most straightforward way to represent it because humans are linear thinkers. So considering it that way, we see how these link together with pre-contemplation. Again, that's, no interest in changing behavior or not enough, make a change. With contemplation, awareness that a problem exists, no commitment to action, preparation, the intention to take the action is actually modifying the behavior, maintenance is that sustained change, and then relapse, again, I really want to emphasize a very normal part of the process where they fall back into the old pattern of behavior. So when you see on the inside here that upward spiral, that's a really important part of educating patients about the stages of change, because it can be so disheartening for them to be moving through these stages and then to continually re-encounter that relapse stage, which again is much more the norm than the exception. And when it feels like they've literally been going in circles, it's really helpful to position them with the perspective that this is actually a spiral staircase rather than just a circle going around and around, because they are learning every time they're moving through each of these stages. So while we usually identify relapse as the most sort of learning rich opportunity, because that's where patients really get to see close up, this is where my skills fell short, or this is where my vulnerabilities really popped into focus. Every time that they pass through each stage, they're learning more and more that can help them get them to where they want to go eventually. And this is an important part of the psychoeducation approach, because when patients can see it laid out like this and understand that they're sort of, this is part of the human process of change of any kind of health behavior, whether it's, ceasing using substances or losing weight or any kind of health behavior, then it doesn't feel quite so daunting when they hit all of the roadblocks that are inherent to each stage. So looking more closely at how these stages match to interventions, pre-contemplation The main intervention there is rapport and alliance building. You really don't want to scare people off when their commitment is already very thin to treatment. So really at most, you might use a little sprinkling of MI here, but you'd want to be very conservative. A typical intervention here would be decisional balancing, where you go through a sort of a pros and cons list. But both the stages of change developers and the MI developers really caution against using MI during pre-contemplation unless it's really warranted, because you can actually cause people to rigidify to their position. Contemplation, on the other hand, where there is that ambivalence, but people are a little bit on the fence, that's that gold zone for motivational interviewing. That's exactly what MI is designed for, and that's where you're going to get the most mileage out of it. So that's when people are sort of two minds about something. There's a lot of ambivalence, and you're helping them tilt towards change if that's where they're ready to go. In preparation, action, and maintenance, MI is not going to be so helpful. There, the interventions are about planning and preparation, where they're getting ready to make the change. In action, you're working on skill building so that they can make the change stick. And in maintenance, you're helping them protect what they've already changed in terms of their new health behaviors through relapse prevention. So again, remembering as we move towards MI at the end of the presentation, it's really best suited and almost exclusively suited to that contemplation stage. So we're going to dig a little deeper into each stage. A person in the pre-contemplation stage might not recognize that there's a problem, or they haven't thought seriously about changing. So you're not trying to push them in any way at this stage. What you're really trying to do is keep them engaged in treatment. That's the superordinate goal here. At most, you're bringing awareness to the problem. So, if they bring it up, you just shine a little light on it. You help them think through what is working, what's not working, what may be a problem here, so that it can come up to the surface and you can work more fruitfully with it further down the line. So the idea here is you're really listening. You're engaging with them in terms of what's important to them, what they're going through, what they're experiencing. You're eliciting more information. So rather than you saying, here, I'm going to tell you what's going on, or, I'm going to tell you where we go from here, you're really gathering a lot of their experience. What have they been through with this? What strengths have they been able to utilize? What is their perspective on the situation? And above all, communicating, caring, that acceptance, the openness that you're with them, that you're on their team, no matter what they decide. In the contemplation stage, that's again where they're willing to make the change, but they're not quite ready to do something about it. And that's where you're sort of just ever so gently tilting them towards action when they express that they're ready for that. So here, when they talk about the status quo, you're not ignoring it or deflecting it. You're just not really contributing to that conversation. Whereas when they start talking about change, you get really excited. You amplify that. You shine a light on it. You make them. You support them in keeping the change talk going. You're also boosting their awareness of change options. An example here that's really common is familiarizing them with harm reduction techniques, because for a lot of people, part of the ambivalence of making a change is thinking that they have to go 0 to 60. Whereas if you can familiarize them with the idea that even moving from using 2 grams a day to 1.75 grams a day is actually a really important step, right? And that can make it feel much more manageable and appealing and move them again in the direction of change. And then also increasing the perceived benefit of change. And a lot of that is about developing discrepancy. So when they say things that kind of highlight, well, on the one hand, I use for these reasons, here are the positive consequences, but then they really don't fit with, for example, my values or, the lifestyle I'm trying to lead with my family. Then you help them to explore that rather than just kind of skimming over that, which is tempting because it's an uncomfortable thing for them to address. So this is where you're really honing in on the values and the goals. An important thing to look out for here as a provider is if you notice discord coming up between you and the patients, that's a sign that you need to move back into the pre-contemplation strategies of rapport and alliance building. This is not a time to argue with the patient. It's very likely if you do that you can push them further back towards the status quo. So you apologize, you affirm, you project that acceptance. And an important strategy here, both for what the client hears and then also for how you're approaching it, is rather than using the phrase yes, but when you have information that's different or perhaps contrary to what they're saying, you say yes, and. When people hear that but conjunction, they tend to think, oh, we're in an argument. And so immediately they tend to get on the defensive. Whereas when they hear yes, and, it's much easier to absorb because it's more of a message of here is some additional information rather than, no, you're wrong. Here, let me give you my information. And then lastly, with supporting self-efficacy, that's helping them to understand that it is very much up to them. They have the ability to make this decision, really reinforcing a solution-focused kind of a approach in terms of what has worked in the past and what really highlights their autonomy for change. In action, a person is ready to make an initial attempt to change behavior, but often there's a lack of confidence or a lack of knowledge about how to go about putting that into action. So your goal here is to smooth the path. You want to make sure that they're really recognizing the progress that they're making, even if it's smaller than what they're expecting. You want to make sure that you can, to the extent that you can anticipate barriers, that you're helping plan to remove them or mitigate them. And also, this is a little bit counterintuitive, but it is an important part of skillful clinical work here. Often patients at this stage get so excited, they've committed to the intention, they're starting to make the changes, they're already starting to see changes sometimes, and they end up with wildly unrealistic goals, and that sets them up for failure. So without raining on their parade, you really want to just take a little time to say, so important that we set you up for success at this early stage. How can we pare this down to fit your circumstances and your resources? Then again, emphasizing that relapse is really a very normal part of the process. That's important both for the provider and the client to remember. Relapse is not a sign of failure, and you want to make this really clear because that does tend to be the default assumption for patients if they don't have this education. You really want to put it into the context of chronic illness management, where relapse is literally part of the lexicon of the course of the illness. And thinking about the word choices that we use, we really want to emphasize that relapse in particular is an incredibly rich learning opportunity where the patient gets a really up close opportunity to identify, where do I need to build my skills? What was it about this trigger that I didn't anticipate or didn't appreciate how difficult it would be? And an important term to introduce here in terms of labeling and predicting in order to change the outcome is the abstinence violation effect. And what that is when somebody has made some gains with their health change behaviors and then they experience a slip, so maybe just a small episode of use, and they start to think, well, I've lost it all, right? They think I slipped, it's all over, all of my gains are lost, I might as well just go back all the way. And this is a really, really common kind of default mode for people to think when they're feeling discouraged after a slip. So if you can predict that they're likely to think that and point out, you do not have to let that turn into a full-blown relapse. That's an opportunity to note, okay, I took a detour, I got off the road that I was on for a moment, but now I have the chance to get right back on instead of fully deviating in a totally different direction. Then people are much more likely to be able to recognize it as it arises and have the skills at that juncture to say, okay, I can make this decision right now. A shorthand that I use for that a patient introduced me to was don't let a slip become a snowball. And I find that patients really appreciate this language because I think that's very much what it feels like for them. So again, in relapse, your goals are to help them avoid becoming discouraged. There's sort of a cheerleader role here and also helping them re-engage in the change process, ideally at a relatively recent junction. If you can help them to re-engage at action, that's going to make things much easier for them than if they have to start back at pre-contemplation. So we're going to pivot here or turn to looking specifically at MI and the spirit of MI. So the big picture idea here is that MI is an effective method for talking with people about change. And the emphasis there is a reflection of the developer's insistence that MI is not a verb, because we often hear people saying, I'm going to MI them into such and such an outcome. And that is very antithetical to the spirit of the approach. And they always say, Miller and Rolnick, that it's you do MI for and with somebody rather than to them or some other similarly hierarchical verb. It's a collaborative, person-centered form of guiding to elicit and strengthen motivation for change. And guiding is distinct there from leading, right? It's a facilitation role rather than a role where you're pulling them in one particular direction. And it's a method that's used when a person may benefit from making a behavior or lifestyle change, but is reluctant or ambivalent about doing so. So again, that's about them being in that contemplation zone rather than, as we talked about, in any of the other stages of change where MI is unlikely to be helpful. So this might seem like a strange way to go about teaching what MI is, but this was a really important essay that the developers Miller and Rolnick put out a few years ago that I think is very helpful for clarifying many of the misconceptions around MI, which is 10 things MI is not. As we've already discussed, it's not the trans-theoretical model of change. They sort of came up together in the same generation and emerged out of the same body of research and are very complementary, but two distinct things. Two, very importantly, not a way of tricking people into doing what you want them to do, which you do sometimes hear this phrase does, let's MI this person into medication adherence. And that is totally antithetical to the spirit of MI. It's never about tricking people. It's always about supporting what is going to be right for them on their own terms. Three, it's not a technique or even a set of techniques. Something that Miller and Rolnick really emphasize is that even if you don't know any of the techniques, but you have a very firm grasp on the spirit of MI, you're going to get further probably than just using the techniques alone, because the spirit is such an inextricable part of how it works. Four, not decisional balancing. It has sometimes become synonymous with this relatively surface level intervention of pros and cons, just because that's something that gets sort of invoked often with MI, but it's much more than that. It's not assessment feedback. I think this misconception mostly has to do with an early piloted form of MI where assessment feedback was incorporated, but that actually turned into motivational enhancement therapy, which is a related branch, but not the same. It's neither cognitive behavioral therapy or client-centered therapy, although both the developers have those backgrounds. It does have humanistic components, but it's definitely more directive than humanistic therapy is. It's not easy to learn, number 8. So people often see MI in action and they say, wow, this looks so simple, it's so elegant, I can do those same techniques, and they don't recognize all the work that's going on below the surface. MI, when it's well done, is so much like a ballet where it's, you might see the techniques, but you don't see all the work that was put into figuring out the timing and the integration, the coordination. So it's very much, at least as much about what is not said than what is said. So easy to mistake for being simpler than it is. And that's related to practice as usual as well, because a lot of times providers will see a bit of MI and say, oh, that looks familiar. I'm doing some of that because clinical intuition will guide us towards things like not pushing a client when they're already ambivalent, that sort of thing. But there's much more to it than that. There's quite a lot of research that's been done to get to MI to where it is. It's not just those surface level things that look like general good clinical practice. And lastly, 10, it's not a panacea. And I think this is important to remember because people can get so excited about MI because it does work so well when it's used in the correct context and at the correct time that they start to think of it as the ultimate problem solver for all patient difficulties. And in reality, it really is only going to work at that particular junction, as we discussed in contemplation, just a smattering in pre-contemplation. It's for a very particular purpose and it works wonderfully there, but we don't want to have unrealistic expectations about over applying it as providers sometimes do. So in terms of research evidence, it's very strong. There's some interesting findings that adding MI to the beginning of treatment led to sustained outcome improvements. And if you look at the second bullet point there, the effect sizes were largest for outcomes related to weight loss, blood pressure, and substance use, which as providers on this echo, we know are very tough things to change. It says a lot about the strength of the approach. I do want to comment on the part that says outcomes were better when no manual was used because it's really telling. This was from a really early series of research studies with MI where they were still developing it and they had a component that required a change plan at the end of each session, regardless of what the patient indicated about their readiness for change. And now, of course, we know that that's totally antithetical to the spirit of MI. That's been phased out for a long time. But at the time, the group where manuals were not being used, the clinicians were tuning into that spirit of MI and they were not pushing for the change plan. So it makes sense that outcomes were better. So that, again, is a comment on the power of the spirit of MI. And then also that it's useful in as few as 1 sessions. And this is part of what makes it so great for primary care and interdisciplinary care models. We really don't have time at this introductory level to go into culturally adapted MI at the depth that it warrants, but I do want to put it all on your radar because it's a really exciting recent body of research. And this is focusing on the fact that MI, because it is very much a patient-led approach, fits very well with multiculturally competent approaches to treatment, where we're honoring the client's context and letting them take the lead in the course of treatment. So there's 3 main components to culturally adapted MI. The first is content. So that's making sure that you're incorporating the cultural values, customs, and traditions into treatment planning. Interesting example here was the researchers recognizing that the traditionally negative health messaging around tobacco use did not fit well for Alaskan Indian Native patients because this was an important spiritual part of their culture, and they used it in very different ways than it's used in mainstream culture in the US. The second C is concept, so that's reframing the treatment model to match cultural importance on specific character traits, or the importance of emic or edic values. An example here that fits well with, if any of you saw Dr. Godomsky's presentation a few weeks ago about the historical context of substance use disorders. In this study, they emphasized the framing of substance use disorders as a community level issue that stemmed from disparities between Black and white American communities rather than the more traditional individualistic emphasis as a pathology. Then the third C is context. So that's consideration of issues such as acculturative stress, availability of social supports, economic or political macrosphere, and the patient's relationship to the country or culture of origin. And this is important in that sort of Bronfenerian model of, what are the nested layers of influence that this patient is working within. They're not just showing up to the office, with no history or context in terms of how they fit into their society and their culture. So looking at the spirit of motivational interviewing, which, as we've said, is really the foundation here, we'll start off with a quote which kind of illustrates for how long this thinking has been around, this philosophy, and that's Blaise Pascal in 1660 said, "People are generally better persuaded by reasons which they have themselves discovered than by those which have come into the mind of others." And that really encapsulates that idea with MI that you're not trying to impose your own ideas on them, but you are trying to help people clarify the ideas and the intentions that they have. One important part of that is that in the spirit of MI, you really want to appreciate ambivalence, which is, in a very brief sense, feeling two seemingly contradictory things at once. So the colloquial expression is feeling of two minds about something. And a lot of the times, if you're not aware of the commonality of ambivalence in behavior change, it's going to look like a lack of motivation. Or even resistance, but actually it's this person being on the fence and kind of internally sorting through both sides of the issue that are already present there. So again, very normal part of the change process. It's very common prior to as well as during habit change. And it's really important to be aware of ambivalence and its role at this stage as a provider, because it really invites us to step into the communication trap, which is where we argue one side of that ambivalence, and the natural response, because of psychological reactance, is that the patient defending the other side. So we're actually accidentally causing them to escalate to the status quo by arguing for change. So if we defend the status quo, that actually makes change less likely, even though that's the intuitive thing to do as a provider. So we call that the righting reflex, the natural inclination we have to make it better for another person. Helpful to remember that it is very well intentioned. The danger is that we tell the other person what to do, how to do it, why they should do it, without actually really talking it through with them, listening, understanding what their own individual motivations and constraints are, and kind of superimposing our own formulaic idea of what it's about. So it creates resistance in that we move away from that partnering, that collaborative alongside stance of MI, and we move into that expert top-down role. So when we think about the righting reflex, why does it happen? There's a lot of inborn assumptions that engender the righting reflex. They don't see or they don't know, so we need to give them insight or knowledge. They don't know how or they don't care, so we need to give them skills or illuminate to them why. And the reality is that when we engage in that kind of thinking, there are a few kind of predictable outcomes, which perhaps the patient makes a change briefly to pacify us if they like us as a provider, but it's not going to stick because it's not for their own purposes. Maybe they'll listen politely and then go ahead and do whatever they were going to do in the first place. I'm sure we all have plenty of experience with that. Perhaps they protest and we continue to push harder and we get locked into that kind of internecine struggle. In any case, nobody benefits, and very often we're drawn to blame the patient by saying, they're resistant or they're not motivated, when that's not actually the case. And I think this is a helpful illustration to remember that when we meet the ambivalence with that righting reflex, we're actually strengthening the muscle of ambivalence. We're actually pushing them further onto the fence or onto the other side, rather than inviting them into the change that they're considering. So how do we resist that? MI loves their acronym. So the rule for MI is, first of all, resist the righting reflex. And part of that is just recognizing that it happens and that we're very vulnerable to it as providers for all the best intentions. Then understanding our patient's motivations, so stepping back, checking our assumptions about what we think they're coming in for, why they should change, and really listening to why it's important for them. And then empowering them, that it is their decision, really supporting their autonomy and eliciting, how is this going to work for you, rather than telling them how to go about it. So when we think about the sort of components of MI, you'll see that those skills and techniques are at the top, but they're a pretty small component. When you look all the way down there at the bottom, the spirit is the bedrock. And as I said before, in what MI is not, the founders really emphasize that if you're going to choose between skills, techniques, and spirit, go with spirit. You're going to get further with that than with skills and techniques without the spirit. So what are the components of spirit? Acceptance, collaboration, and evocation. We'll look at this a bit more closely. With acceptance, we're talking about absolute worth. That's that very humanistically oriented part. That's positive regard in the absence of judgment. That's, they may be continuing to use, they may be making a lot of choices that don't make sense to you, but you're not judging them for that. And the Rogerian paradox there is that when patients experience being accepted as they are, then they no longer feel like they have to defend who they are. They're free to change. They don't have to be attached to the way that they were doing things. Another part of this is accurate empathy. So that's striving to understand the other's internal perspective, their meaning and their values through their eyes and on their terms. And accurate is an important distinction here, because you certainly, one can be empathic and intend to be empathic, but it's not always so accurate if we haven't fully checked out where the patient is coming from. And then autonomy support, acknowledging that their freedom to make choices, it's their own attitudes, their own behavior, you're not putting it on them. And the affirmation of actively communicating appreciation for their strengths and efforts. Sometimes that's about, you showed up to treatment, maybe you haven't made any of the changes that you thought you would, but you're still showing up to treatment, and that's a huge deal. That's a really important part of the change process. So finding ways to highlight the strengths and what they have accomplished. So the sort of counter positions here are autonomy and authority. In autonomy, we're affirming the patient's right and capacity for self-direction. We're facilitating informed choice, so we're making sure they have the information to make the decision that's right for them. And we honor that choice regardless of how well or not well at all it fits with our hopes for them or our intentions as treatment providers. The counterpoint there is authority, the sort of traditional, more anachronistic model, where we're telling the patient what they have to do in a very directive manner and assuming that they're incapable of making informed decisions and that we have to instruct them in what to do, partly because they're still using an implicit assumption there. With collaboration, that's about active collaboration between experts, right? So we may be experts as treatment providers, but they of course are experts on their own life, and there's no way we're going to be able to touch that level of expertise. So the model here is dancing rather than wrestling, this kind of coordinated exchange between equals rather than a sort of domination-oriented approach. And it's about exploring more than coming in with that agenda of, I'm going to persuade them to this perspective, right? It's about just going on that journey with them together to discover what's going to be helpful for them. And again, emphasizing the language, it's conducted for and with a person rather than to them. So remembering patients are the undisputed experts on themselves. They usually do know what they need to change, and often they actually already know how to do it. So you're really just there in that supporting role. With collaboration, the counterpoints are between collaboration and confrontation. So the idea of developing a partnership that honors the patient's expertise and perspective versus being required to override the patient's impaired perspective by imposing awareness and acceptance of reality. It's sort of that classic paternalistic model of, they don't know what's best for them, so I need to tell them. And then lastly, evocation. And the idea here is that the patient already has what they need and that you're just there to help bring it to the surface, bring it out to where they can fruitfully utilize it, that the motivation, the resources are already within them, and that they don't have to wait until they are ready, which is this really nebulous concept that often holds patients back, that you're there to support them, and that if they have the intention of being ready for change, then you can get that change rolling, even if they're not feeling confident yet, because that's part of your work with them is supporting their confidence and their skills. And you're just evoking and strengthening the motivations that are already there. You're not trying to introduce new ones or superimpose your own. You're really seeking out their why, how it's going to be important to them, what's on the other side of the change that makes it worth it to them. So in that way, understanding their perspective and wisdom. The counterpoints there are with evocation, enhancing their intrinsic motivation for change by eliciting their perceptions and their values, versus that older model of top-down education, where we're sort of looking at them as having deficits and we're providing that required education. It always makes me think of that quote, I think it's Yeats, about education is the lighting of a fire, not the filling of a bucket. And I think that really encapsulates those kind of counterpoints between evocation and education. So in conclusion, just using these images to kind of encapsulate that idea of treatment with and without the MI spirit. If we're using that kind of, more old school, top-down paternalistic approach, it does feel like wrestling. It does feel like an act of domination. Whereas if we're really embracing the spirit of MI and doing that collaborative alongside work, then it can feel like dancing. It can feel lovely and really engaging, and that we're very much on the same plane as our patients.